Good afternoon, Joe and Peter. Um, so today is a sort of a kind of some hard news. And Peter, I wanted to start with going directly to the kind of UK's numbers. I've just been looking on Infometer on the kind of the latest mortalities, and um, on March 25th, we had 41 new deaths. On March 26th, we had 115 new deaths. On March 27th, we had 181 new deaths. And for those of you who aren't on worldometer.info, it's a really, I think, valuable resource. And the graphs on it are sort of staggering and not very encouraging. So Peter, tell us a little bit about, where you think we are in the UK. The graph looks an awful lot like Italy, I'm afraid.
It's unfortunately exactly right. We're in what I sort of think about as the quickening phase of this, right? And this is what exponential growth looks like. We've talked in the past how trying to assess a trend from the number of reported cases is a little bit dubious because we know that not everyone is going to be tested, particularly in settings like the UK where they're just not doing a lot of tests outside of hospitals. So it's hard to know what the real value is. And we think there may be 5 or 10 times more cases than are reported, but who really knows? With deaths, it's different. Hospitalizations and deaths are pretty good proxies for the actual epidemic curves because you're not going to miss a lot of coronavirus-related deaths. People aren't going to sort of die in obscurity and not be tested. What we're seeing is that the curve, as you described it, for the number of deaths in the UK is tracking the reported cases, and that is growing really exponentially. I mean, the overwhelming majority of deaths in the UK have been reported just in the last 4 or 5 days, and so we saw the same thing in the US, where to get to the number of deaths we had yesterday, it took almost 2 months to get to the first 50%, and then 3 days to get to the second 50%. So this is happening. And it's happening quickly. It tracks with the reports that we're getting, if you're following the news media, about the scenes in some of London's hospitals, right, where they're already beginning to be overwhelmed, not only short of equipment, but ICUs being full, really difficult triage situations. And unfortunately, it's just the beginning. The measures that have been taken, which I think we'll probably talk more about in terms of the so-called lockdown and things like that, while we hope they're going to be effective, as we've talked about, those are not immediate, right? Those are things that are only going to be reflected about 2 weeks later because you're preventing new infections, and it takes a while before people get really sick and die. So even if we're doing an awesome job with the lockdown right now, we would still expect to see a big surge in the number of cases and, unfortunately, the number of deaths in the days to come.
So, how do you feel about the kind of surge in volunteerism, the opening up of the Excel Centre, the efforts to try and provide greater medical equipment? It seems as though, belatedly, unfortunately, there is a big surge in trying to provide both hospital beds and not particularly well trained personnel, although bringing back retired NHS workers and putting medical students onto the front line will certainly, those are skilled people into different degrees. Do you think that the inadequacy of bed space that we've seen in the UK relative to, say, the continent is going to be able to be remedied in the short term by some of these measures?
I don't know. It's good to see it happening. I mean, first off, the response to the call for volunteers to help the NHS has how much kind of difference that makes, and questions about protective equipment and things, but it really kind of reinforces the sort of communitarian spirit of Britain that I've always loved, and so it's been nice to see that. myself and my wife, we're still potentially is underway, and that's going to need to be ready within days, because the hospitals are going to be over capacity within days. We're also now seeing reports of similar efforts in Manchester and Birmingham and some other places to build these kind of temporary large-scale field hospitals. That's great. We need them, and unfortunately we need them quickly, but in addition to sort of space and beds, you have to be able to have the right equipment. We know there are still ventilator shortages. There are going to be personnel shortages. There are going to be PPE shortage safely, effectively. It's difficult to do that when you're sort of, almost making it up as you go along day by day. So if some of these hundreds of thousands of people are going to be deployed, even the retired doctors and nurses, getting them integrated and trained up, and hope the early warning signs, that this was a real possibility. So I think it's going to be, it's great to see, and it's going to help. I don't know if it'll be enough, and I think it's going to be quite chaotic. And one of my concerns is about the folks on the front lines, of course, being at risk. And we've seen in Italy how hospitals themselves can become epicenters of transmission if you can't separate the COVID patients from the non-COVID patients, if you can't protect health workers. We could all be on lockdown in our houses in the meantime, but then people going in and out of hospitals, including health workers, are actually still driving the ongoing transmission of the epidemic, and that would be a real catastrophe.
This is a conversation for another time, but I do want to flag it. I just read a very alarming report that, if it turns out to be substantiated, and there's no reason to believe it's not, in The Guardian, about efforts to stockpile and prepare PPE and protective equipment within the NHS a couple of years back, and those being rejected on the basis that it was too expensive and unaffordable in the context of a big sort of austerity drive. And I think that it's at moments like this that it's important, the most important thing is to think about saving lives, but a general question about preparedness, where societies make their investments and how they invest. I think there is going to have to be a deep conversation and a reckoning when we build back better after all of this about what we should have and could have done.
Amen. And I don't know about that report specifically, but we know that after a decade of austerity measures, the NHS has been underfunded. We know there was already a shortage of at least 10,000 health workers in this country. And so that's the baseline at which we're starting from. We sort of started with one hand tied behind our back because our systems are so weak because of years of underinvestment. Unfortunately, we're going to pay the price. And hopefully, at the very least, that will catalyze some conversation about what we can do differently in the future.
Before we started broadcasting, we were speaking about a rather remarkable fact that the Prime Minister, the Health Secretary, the heir to the throne, and now the Chief Medical Officer is reporting signs of COVID. These are the people who are, in some ways at the pinnacle of our society, and at least three of those have been kind of at the front line in sometimes daily briefings, either communicating with or reassuring or not the nation about how the country is dealing with this. And we obviously all wish them a very speedy recovery. But it strikes me that, everybody has been affected. And it also strikes me that those people who are wielding tremendous responsibility, it's hard that they've all got it at this moment.
Yeah, it's striking that it sort of happened all at once. The two or perhaps all three of the ones that we've been used to seeing in a lot of these daily briefings, all at the same time, along with the Prince of Wales, of course. As you say, it's a real reminder that this affects everybody. And I think To an extent, that's a wake-up call, I think, for all of us, that sort of no one is sheltered, and with lots of other past epidemics and other kinds of diseases that disproportionately affect the poor, communities of color, et cetera, it's easy for some to kind of avert their gaze and neglect that. And I guess what's different is that we're sort of all in this, whether we like it or not. It's concerning because we need all of them right now. We need them all to be successful. And so to have a big part of that kind of leadership and brain trust be potentially incapacitated or ill at the same time is disturbing. And it's also, I think, the same way that concerns me is the way we should be thinking about what's happening in our hospitals and health systems right now. Because if we start to lose doctors and nurses for weeks at a time because they themselves are getting ill, all the ventilators in the world and all the beds in the world are not going to help us, because we need them there on the front lines. And so it's kind of a sign of how I think challenging this this can be.
I want to pivot to the US, because the US has achieved its own milestone as sort of the place with the largest number of infections in the last 24 hours. And against that backdrop has been, and I know it can be in certain circles fashionable to bash Trump and to comment on his idiosyncrasies, but even by his standards, I think the most recent pronouncements are verging on deeply, deeply morally irresponsible. And so on the one hand, saying we'll be up and running by Easter, which sort of sends a signal to people that this is not serious, it's a passing moment, and we'll soon be out of it without having to adopt significant behavior change. And then on the other hand, adopting this idea of finding counties that are high levels of infection, medium levels of infection, and low levels of infection. And then, as I understand it, but I'm not sure, and maybe you can clarify, stipulating different forms of behavior and conduct in each of those, and then not really giving a protocol about what happens when people move between them. If I were in the US right now, I would be very, very, very confused as to what I should be doing based on what's coming out of the mouth of Donald Trump versus Andrew Cuomo, the governor of New York. It doesn't seem like a case study in consistent leadership.
That is the understatement of the day. That's true. U.S. doesn't have a plan. They don't have a plan. They don't have a strategy, and there's very little federal coordination. So there's very much a patchwork approach. To an extent, that is something you might expect, in that there's a lot of decentralization in the U.S., and so the states have a lot of authority. But in a perfect world, there would be much more federal coordination, because, of course, people move across state borders and pathogens move across state borders. We're now seeing scenarios in which states are competing with one another to buy PPE and to buy ventilators, and there are price wars where states are outbidding one another. And so there's this kind of like Hunger Games-esque competitions between states to get this stuff, rather than having the federal government help to coordinate that and get things where they need to get to the most. That's a real example of the federal coordination that we need that's not happening. This notion of being able to sort of implement different targeted strategies in different counties or different places, in theory, there's some merit to it. We saw that be successful in some of the Asian countries that have beat this back early on, but they did that by acting early before there was a lot of community transmission, before that got out of control. And they did that with a basis of widespread testing and really, really surgical kind of contact tracing and isolation. That allowed them to be really targeted and say, we don't need to close all the schools and all the shops and all the businesses, but we may need to do that in certain places. Early on, you can do that. You can't do it in the US anymore. It is the genie's out of the bottle. It's everywhere. We know it's bad in New York and some other places. But if you were to go to the Johns Hopkins coronavirus map, which is another sort of great resource, and just look at the US, where there are all these kinds of red circles, there's no place left untouched anymore. And so it's not possible. Honestly, I think that the only way in the short term to slow things down is essentially a nationwide shut down, much like we've sort of seen here in the UK, or a version of that. New York is where it's at, and there's some evidence that maybe some of the measures in New York, which have been quite strict, might be starting to bear fruit, but they're still overwhelmed. New York is the new Wuhan, and in a week or 10 days, we will have several Wuhans in the US unless there's a course correction, very soon. And that's a big deal, because even in China, as bad as things got, there was one epicenter and things radiated out from there, right? So you could make control measures that were really aggressive in the center and then gradually different as you work your way out. Imagine having 3 epicenters or 5 epicenters or 7 epicenters, 7 Wuhans at the same time. You're just not going to be able to control that. And that's why I think it's time to pull at all the stops and shut everything down, because they're on that same place in the curve that the UK is. And so, we're going to see 10, 20,000 new cases a day within a couple of days, and then that's going to go up and up from there. And New York is just a sign of things to come around the rest of the country unless we get serious. And that's why the rhetoric coming out of the White House is so dispiriting, and I think so destructive. And there's no way we're going to ease anything off by Easter, because if anything, we're going to be approaching the peak around Easter, and it's going to be bleak. Sorry, good news, Dr. Drobac.
I mean, in some ways, I literally find myself staring at the ceiling and grappling with what it is that can be done, because you can imagine responsible governors and responsible mayors, adopting a series of measures, but when they are competing for airtime and the Twitter sphere, with the president who's sending a very different message, and in a country where everybody is receiving their news in their own politically self-reinforcing echo chambers, it's a real worry that it's going to get far more serious than the top-down approach that you could implement in China, which was draconian. And contrast that with India, where Modi, in classic, strongman style, locks down the entire 1.3 billion people for 21 days with, in some cases, 4 or 5 hours notice, which has its own very, harsh humanitarian consequences. Okay. Well, can we talk about India a little bit? Because I think, we spend a lot of time talking about the countries in the north, but tell us about where you think this goes in the global south. And India is the real example of a very extreme approach, which will probably have its own consequences. But let's discuss India.
Yes, overall, India is earlier on in sort of its epidemic than the countries that we've been talking about, and that's why it was noticeable, I think, when Modi announced the nationwide lockdown a couple of days ago. And we're also talking about, what approximately a sixth of humanity in that country. And we've been saying again and again that what works is early aggressive action. And this certainly qualifies as early aggressive action. And so I think the idea was to try to get this under control before there was a lot of community spread. And so for the most part, in the abstract, I think that's a really favorable thing and a good thing to do. I don't know how successful they'll be in enforcing that lockdown. And I worry about the consequences for folks who are living on the margins, right? For a lot of us, we had time to sort of, stockpile some food and dry goods and toilet paper or whatever. B, we have means and resources. We'll figure it out. If you're living on the margins and you can't do that, and you don't normally know where your family's next meal comes from, imagine being just shut in without any sort of notice, and you get arrested if you go out. So there could be some real and very proximate consequences for the poorest in India, unless there are strategies to deal with that. I haven't heard anything convincing about government or charitable intervention at the level that's probably going to be needed. So I worry about some of the consequences of suffering that will come from that. At the same time, the counterfactual is pretty bad, right? It's a massive country. It's tremendously densely populated. There are aspects of its medical system that are really impressive, but it's tremendously unequal. And so you can get amazing medical care if you can afford it. And if you can't, it's not so hot. And so the consequences of an Italy-like situation in India would be really hard to imagine. So on balance, these are two terrible options, but I think it makes sense what's happening there right now.
I'm sorry to bombard you with all these kind of quirky questions, but I wanted we've spoken earlier weeks about Germany.
Mm-hmm.
And I'm just going, one of our members who's online basically said, what are they doing, have done differently in Germany for their death rate to be incredibly low in comparison to their affected population? And I'm kind of looking, Germany, March 24th, 36 deaths, March 25th, 47 deaths, March 26th, 61 deaths, March 27th, 37 deaths. And so Germany has, compared to the UK at least, and certainly compared to a bunch of other places, recording fewer deaths. Now, that may, the jury's out, this is a small data set, but is there anything that we can know about Germany that might be applicable elsewhere?
Test is the first big thing, right? That was one of the things they started doing really early, which was testing a lot of people. I can't say testing every day, but testing a lot of people, testing people who were asymptomatic, right? One of the things that we're learning, almost more and more and more, the more time goes on, is how significant asymptomatic transmission, that means I'm infected, but I don't have any symptoms and I'm infectious or contagious to other people, how significant a driver of the epidemic that is. And so that's what makes strategies of just self-isolation or just testing people when they get pretty sick fall short. So what Germany did was test a lot of people, and they caught a lot of the people who maybe didn't even have symptoms yet. So in one sense, that will drive down your fatality rate because you're going to have a bigger denominator because you're capturing more of the cases. What that also does is get those potentially infectious people out of circulation a lot earlier and before they can go on to infect one or two or three people others. So that also helps with your driving down of the R naught. Can't remember how much we sort of talked about that, but on average, right, one person infects 2.5 to 3 others during the time they've got this virus. All the stuff that we're meant to be doing is about driving that number down to less than 1, because that's when the epidemic curve starts to actually go down. And so testing people early and giving them a diagnosis and then getting them out of circulation so they can't infect others, I suspect is a big part of also why the death rate has remained low, because you're not seeing as many severely ill folks in the hospital. I don't know if it totally explains it, to be honest. If you just look at raw numbers, it's just so much lower than so many other places. A week ago, I suspected that it was just really early in the epidemic, and as things continue to progress, we'd start to see a higher death rate. It hasn't really happened yet. So I think there's still a question mark for me, and I'd love to know why.
I wanted to ask you a vaccine question. At least, I know you've said before 12 to 18 months will be the world record. I've been doing some reading. There's 47, and I'm sure there's even more vaccine initiatives all underway at the same time right now, all using different little splices of the genetic material of COVID-19, and there are some actually which are beginning to be implemented in human trials as we speak. Now, I wanted to ask, prior vaccine development was you take a very virulent disease, you dilute it down painstakingly in a lab, and then you introduce it to people and you hope that they build antibodies. Mm-hmm. This new generation where you actually have genetic sequence, you'll be able to look at the gene structure of the actual disease, and you can take little splinters of genetic code and you can actually manufacture them and then put them in, are there reasons to believe that strategy is going to be more accurate and more targeted and lead to better results? And therefore, although the vaccine is not going to save us in 12 to 8, because it's going to come in 12 to 18 months, this sheer level of global investment in it is very likely to get us a vaccine that will stop this thing ravaging us again?
Yeah, I think the short answer is the diversity of approaches gives you a lot more bites at the apple,
Yeah.
and that increases your chances of success because of diversification. So, will we see? I think that the advantage of the kind of using genetic information to sort of manufacture different proteins and things that could then spark the immune response that you want from a vaccine without actually injecting a pathogen. The big advantage there is speed, because being able to do that in the laboratory now is something one can do quite quickly. Those are not the only kinds of vaccines that are under development right now. The kind of old-fashioned versions where you create inactivated versions of virus, or you culture virus and then you destroy it all, and then just use kind of the remnants in vaccines. Some of the older techniques, those are happening right now as well. Initially, interestingly, a lot of them were all focused on the newfangled technologies. There's a group called CEPI, CEPI, the Center for Epidemic Preparedness Innovation, that's coordinating and driving funding for a lot of these efforts. And a lot of them was focused on the kind of newer stuff. They've also now broadened and said, let's go for some traditional vector style vaccine approaches as well. There's one actually in Oxford that is just planning to begin human trials in the coming couple of weeks. That is a more traditional one. So that's great because you just never know, right? And what you don't want is 6 pretty similar approaches that all have the same fatal flaw, and we don't find out for 6 months, right? So what this means is that if some of these efforts falter in the coming weeks and months, as they certainly will, there's a much better chance that one of them is gonna come through and be successful. So that's exciting, and I haven't seen an effort this sort of robust and diverse and fast in terms of sort of medical discovery in my career. So cool to see.
Is this at a scale that is just 10x larger than anything that was done on Ebola or SARS or MERS? Is it sort of just on the sheer number of trials and the sheer amount of investment? Should that alone, is there something about, like, it's like playing roulette? You just put as many different chips on as many different places, and then you hope your number comes up. But if you do a lot of intelligent chip placing, you're likely to get a vaccine? Or are the odds so infinitesimally low that it's not really like there's 36 numbers, there's a billion numbers, and even if you do 10x the number of vaccine trials, you can have all of them be unsuccessful?
Yeah, I don't have the figures in front of me, so I can't sort of compare the amount that's been invested or committed so far to other epidemics. But yeah, there's so much energy and attention investment. One of the things that's also different about this moment is that there's no other research happening. Right? If you look at least in universities where a lot of medical research happens, early medical research in particular, all of it's been shut down because people are all sheltering in place everywhere. It's literally all on hold. So anybody who can be doing research on COVID-19 probably is, and there's a lot of investment for that. So, that's going to have some other consequences, and that it'll set back other urgent and important research for periods of time because we just can't get into the laboratories. But there's a lot of effort on this, and we don't know. There's never been a successful vaccine for a coronavirus before. We got pretty close with SARS, and we got pretty close with MERS, and then all that stuff was shelved when the epidemic went away and the funding dried up. Oops. But we've dusted those things off, and those are underway as well. I have a lot of faith in the power of human ingenuity to figure this out, and I think we will. And then the other side of things is that, like, every day there are new developments in diagnostics. Lots of exciting news about rapid tests. Viewers in the UK will have seen the announcement about this home-based testing kit that the government claims to have bought 3.5 million kits that will not test for the virus actively, but will test for antibodies that show past infection and at least imply immunity. So that's an amazing way for us to figure out how far this infection is spread through the population, and whether we as individuals have already had this and might now be immune. There are a number of those kinds of tests now starting to appear all over the world. Really exciting announcement yesterday about one being developed in Senegal in a partnership with a company here in the UK, Mologic, and that is geared towards developing countries, right? It's a $1 10-minute test that they want to roll out at cost in sub-Saharan Africa, in other poorer economies. And that's terrific because I haven't seen any of that happening so far. So lots of exciting movement and moving almost as fast as the bad developments. So fingers crossed.
Final question, then we'll let you go and start your weekend. So if you could roll out that home-based self-diagnostic and you got millions and millions of people to discover, many of whom, for the reasons that you said prior, it turns out that this disease has been asymptomatically transmitted for a long time, and much larger numbers of people have had it asymptomatically. If you've had it asymptomatically and have had no symptoms, would it follow then that you could in fact go volunteer and not be at risk, go back to work, start serving in restaurants, could this be the pathway to beginning to restart economies and allow us to return to normalcy, because people who've had it are unlikely to get it again in the short term?
It could, and it's super important for all the reasons you say. So this is what we call serologic testing. They're tests that look for antibodies in our system to the virus. And there's two kinds, one called IgM, which you get immediately after infection within weeks, and IgG, which is the one that usually lasts longer. Now, again, we don't know for sure how immune a person gets after getting infected. But our assumption is that people have a significant level of immunity after infection, meaning they're unlikely to get infected a second time. We just haven't seen much evidence of people getting reinfected. So that gives us confidence, even though we haven't been able to prove yet that that's the case. So our assumption is that if someone has been infected and recovered, and even more so if they show levels of antibodies in their system, that they would be safe to do that. So if we can start, or when we can start rolling out kind of serological surveys at a population level and know whether 2% or 5% or 50% of a population has been infected, that's really important. And then, as you say, people being able to get back to work, hugely important. My one concern about the idea that there are going to be 3.5 million tests that any of us can order on Amazon is, are they keeping track in some way, shape, or form? Because this is really important data. Yes, I want to know for myself, but it's important that we know everybody who's been tested and whether they tested positive or negative. Like, we need that intelligence. So, I'm not for like Big Brother with data, but there should be a way to track everybody who has a serological test and who is showing some immunity.
There should be a legal and a moral obligation. If you get one of these tests, you need to report it out, because it's in everybody's interest for us all to know.
Yeah, and I think people would and largely will. I just haven't seen that part of the plan yet. I hope it's there. It's going to be really important in helping us to pull ourselves kind of out of this mess over the next couple of months.
Peter, as always, thank you so much for joining us. Have a wonderful weekend, and I hope when we see each other next week, we have some better news in other pockets of the world. But have a good weekend and stay safe and stay well.
You take care, everyone. Thanks.